Your examiner presents a 56-year-old female with a 6-week history of progressive left breast swelling, pain, and redness. She has completed a 10-day course of antibiotics prescribed by her GP. There has been absolutely zero clinical improvement. In inflammatory breast cancer, or IBC, the temporal presentation is a defining feature. The onset of symptoms is rapid, typically developing in under 3 to 6 months. The patient will describe a distinct physical sensation of a heavy breast, accompanied by a constant, dull, aching pain. The presentation often mimics acute mastitis. However, when suspected mastitis fails to respond to antibiotics in a non-lactating woman, it becomes an immediate diagnostic concern. Defaulting to an infection diagnosis in this scenario is a frequent point of failure for candidates. It delays the identification of an aggressive oncological emergency. You must verify specific risk factors with the examiner. Ask about the patient's age, nulliparity, any history of hormonal and fertility treatments, and a family history of breast or ovarian cancer. Next, dictate a targeted systemic review to screen for stage 4 metastases. Explicitly ask if the patient is experiencing bone pain, shortness of breath, or unexplained weight loss. Observe erythema covering more than 1/3 of the breast surface, combined with skin edema. This dimpling, known as peau d'orange, occurs when tumor emboli obstruct dermal lymphatic channels, causing edema that tethers the skin down to the hair follicles. Upon palpation, the breast feels diffuse and hard. A distinct palpable mass may or may not be present, a common finding in T4D. Instruct the examiner that you are checking the axilla for matted or fixed lymph nodes and palpating the liver and spine for tenderness to rule out distal spread. T4D IBC differs from advanced non-inflammatory cancer, graded as T4B. A T4B tumor presents with explicit skin ulceration, or cytolite nodules, rather than diffuse, widespread erythema. Inflammatory breast cancer is a clinical diagnosis. You must recognize the physical pattern of rapid onset and widespread skin changes before you order imaging or biopsies. Once the physical exam is complete, the examiner will ask how you plan to investigate this hard, diffuse breast. Your first-line imaging modalities are a bilateral mammogram and an ultrasound. You are looking for a BI-RADS-V classification, characterized by skin thickening, stromal coarsening, and suspicious axillary nodes. To secure a definitive diagnosis, you dictate a 3-part biopsy protocol. This targets 3 distinct anatomical depths. Target 1 is a core needle biopsy of the breast to confirm invasive cancer and determine the molecular subtype. For triple-negative cancer, this means negative tests for estrogen receptors, progesterone receptors, and HER2. Target 2 is a skin punch biopsy. This identifies pathognomic dermal lymphatic invasion caused by tumor emboli. Target 3 is a fine needle aspiration of the axillary nodes to confirm regional nodal involvement. Because IBC presents as a minimum stage 3 disease, full staging is mandatory. Order a CT of the chest, abdomen, and pelvis alongside a bone scan to rule out M1 distant metastases. Treating a patient without completing this multi-layered diagnostic map is a departure from standard oncological care and will compromise the candidate's standing in the exam. At this point, the examiner may ask if you would book the patient for a mastectomy the following morning. You must decline. Upfront surgery is an absolute contraindication in inflammatory breast cancer. The first step in management is neoadjuvant systemic therapy, or NAST. For triple-negative IBC, the standard NAST regimen utilizes an anthracycline and taxane-based chemotherapy protocol. You must monitor the tumor's regression continuously during this phase, through clinical examination and imaging. NAST is a biological prerequisite. It shrinks the diffuse tumor burden, which is the only way to make definitive, clean-margin surgery physically possible. Assuming the patient has shown a favorable response to the neoadjuvant chemotherapy, you proceed to the surgical phase. State that the necessary procedure is a modified radical mastectomy, or MRM, with a level 1 and 2 axillary lymph node dissection. Using this anatomical wireframe as a guide, dictate a transverse elliptical incision that includes the nipple areola complex. You must ensure a minimum 3 cm clearance from any involved skin. Raise the superior flap to the level of the clavicle and the inferior flap to the rectus sheath or the inframammary fold. Remove the entirety of the breast tissue along with the pectoralis major fascia. During axillary dissection, identify and preserve the medial long thoracic nerve and the lateral thoracodorsal bundle. Remove the level 1 and 2 nodes, using the axillary vein as the defined superior limit of your dissection. Dictating these precise boundaries demonstrates your ability to achieve oncological clearance while protecting critical nerve structures. Immediate postoperative care includes monitoring drain output until it is under 20 to 30 milliliters per 24 hours, encouraging early arm mobilization and providing DVT prophylaxis. Post-mastectomy radiation therapy to the chest wall and regional nodes is mandatory. This is required regardless of the tumor's initial response to chemotherapy. Long-term follow-up requires clinical exams every 3 to 6 months for 2 years and an annual mammogram of the contralateral breast. Before concluding, you must address the critical errors that frequently lead to exam failure in this scenario. The first critical error is attempting breast-conserving surgery or an upfront mastectomy. These approaches lead to positive margins and rapid local recurrence. The second error is performing a sentinel lymph node biopsy. Inflammatory changes and tumor emboli physically block the lymphatic channels. This renders radioactive tracer mapping inaccurate and leads to false negatives. Any suspected mastitis in a non-lactating woman that does not resolve within 2 weeks requires a biopsy. Success in this viva scenario depends on recognizing clinical danger signs early and strictly following the neoadjuvant first multimodal pathway.